because of the delay in program. No further delay, I would like to introduce my close friends, Professor Derk Krieger, who's going to update us about a very interesting topic, which is Alzheimer's disease. Now is the time to talk, and he's the expert in that region. Area. Please welcome Professor Derk to the stage. He's a professor of neurology at Mohammed bin Rashid University and a senior consultant neurologist at MedClinic Parkview. Welcome, Derk, please.
Sorry. Thank you very much for the introduction. Thank you very much for organizing this superb symposium on dementia. I thank Abu Bakr and Suhail for their interest in this topic, because I think it's a sea change, and we saw this in these 3 talks. And I just want to pick up on a little bit of these things that were said from the other side of the pond and bring it a little bit into our perspective. So this is a short review with a focus on the amyloid beta depletion, and I think it's the time to talk about Alzheimer's disease, not only amongst ourselves, but also in the community, because it is very difficult to recruit these patients for several reasons that we can discuss later. So this is actually a depiction of an artwork of a caregiver of a Alzheimer patient of mine, and this is how she sees this brain losing all of the vigility of her late father before he died with Alzheimer's disease. So this is my disclosure, and let's start. So the number of people with dementia in low and middle income countries compared to high income countries will increase, as you can see here. Let me see, is this the, yeah, this is the, not very well. The darker red is the high income countries, and the low and the middle income countries is the orange. And it actually increases much faster than in the high income income countries, probably because of the fact that a lot of other health and lifestyle issues are being addressed in those countries more than the low and middle income countries. On the right-hand side, we see a depiction from the nun study, from the Centurion nun study, and we can see that most of the Alzheimer's disease in blue occurs in the earlier decades of life, as opposed to the later cases after age 70 and 80, where Lewy body disease and vascular dementia becomes more of an issue. This is how the Middle East, this area here, although the data is very weak and we need better studies, but this is how it compares in terms of Alzheimer prevalence with other regions in the world. So, you know, if you look at Australia, Asia, and so forth, they all rank between 6 and 8. Eastern Europe here a little bit higher, and the Middle East at 6. So 6 adults among 100. So 6% of the adults above 60 diagnosed with Alzheimer's disease. And the only countries that are lower are those of in Africa, sub-Saharan Africa, probably for reasons of under-recognition, I would think. So we compare here in this region pretty much with the other areas, and it is a prevalence of 6% in people above 60. And I think this is a number to remember. It's a lot. Well, this we already talked about a little bit, and I don't want to use my time on it, but it is the current concept, how we manage dementia. So it is increasing the brain cognitive reserve, it is reducing any brain damage, and it is reducing brain inflammation. Those 3 things together will probably be sort of a background, I would say, to specific therapies that will help with Alzheimer's disease. So I think this is like, when you compare it with migraine, this is like using the repurposed medications to reduce the triggering for the actual migraines, whereas the actual treatment would be involved in the pathophysiology, and we know which medications I'm talking about. So this is an interesting slide because it shows what we all think about, the genetic risk of Alzheimer's disease. So the frequency of the genetic alteration in the population increases to the right, and the odds ratio of being associated with Alzheimer's disease increases with a Y. And you can see that there is we already heard about the presenilin mutations and others, the APO4, and so forth, but there's a host of other genes that are associated with Alzheimer's disease, and you can see that they are from various areas that are not necessarily associated with neuro disease. So this is just as an interesting side fact. And this is, we've already talked about this as well, this is an area of what does affect lifestyle factors, what effect do they have on Alzheimer's disease. And you can see here in the young age it starts with schooling, everything on the green side is positive and everything on the red side is negative. And you can see here, just to pick a few, more schooling is important to increase the funders of knowledge. And then up here on the red side is, for example, obesity and things like that we don't have to go into detail now, but they are associated with increased numbers of Alzheimer's disease. This we have already seen. We don't have to go into any details, but this is unfortunately not yet available in this country, although PET scans can be done. The problem is that the tracer is not yet available, and it may be made available in the near future, and I think it will be made available in the near future if there's a higher need for it. This is a very interesting slide, and the previous lecturers mentioned a little bit about this. This is a study that was conducted in Medellin, Colombia, on a large kindred of patient, a family with 5,000 members, and they had the dominant presenilin E280A mutation, and they were followed with that marker that I showed you before over their lifespan. So basically it started at age 20 and it ended at age 60, and typically the dementia kicked in between 40 and 50 in these patients. And it is here now, as you can see, distinguished between the non-carriers, the asymptomatic carriers, the mild cognitive, and then the demented carriers. And you can see here that there is a 16-year time difference between the first recognition of the pathology, of the amyloid pathology in the brain versus the diagnosis of dementia. Or mild cognitive, and 21 years before dementia. So 16 years before mild cognitive decline is diagnosed, the pathology can be seen in the brain. What does it tell us? It tells us that the early Alzheimer's in the 60s, the pathology is in 45. And I think this is very, very important to keep in mind. This is the second bullet that I would like you to keep in mind, because the pathway in which we use this drug, or in which this drug has been used in the pivotal studies, you know, they're starting it very, very, very late. So if everything's dead, what are you expecting? So I think over the next years, over the next decades maybe, it takes some time, I think we need to move towards using this a little bit like in the mindset of Lipitor versus Crestor versus these statins that we all take because we don't want to have a stroke. And we need to move in this direction. Of course, there's a long way, and I'm not saying this should be done right now, but this is where our mindset should be. This, we don't have to go into. It just puts together all the pathology that we know about it, and the fact that amyloid seems to initiate the pathology along with the inflammation that's going on, and then the tau is a little bit later involved and signalizes a point of no return. So if the tau is involved, it seems unlikely that a lot of good can be done with these medications. This is an interesting study recently published 2019 in JAMA, just making the same point. They looked at a cohort of patients with or without Alzheimer's disease from a memory clinic, And they were looking at the amyloid beta scans, the tau scans, and then the final cognitive outcome. And they saw over a period of 3 years, at least in this study, that it started with pathology of amyloid beta, and then you saw later on in blue the tau level increasing, and then at about 3 years, the cognitive decline kicking in statistically in this analysis. So it mirrors what we were just talking about, that it starts with amyloid, then tau, and then cognition. This is the physiological principle of the drugs that Dr. Tarazzi just talked us about. All of them, what they do is they target the amyloid, and they try to target it and then flush it out through the endolymphatic system of the brain, which has another name that just escaped me, but that's maybe my age. Anyway, this endolymphatic system of the brain captures all of the amyloid and then transports it into the lymphatic system and is being discharged in the body. This is the way the amyloid targeting medications work. They work on amyloid plaques, on fibrils, and on the protofibrils, of course. And this is how they target them. We heard about this in the talk. I don't have to go into any further details. And if they then have targeted them, they can be discharged through these waste cycles that I mentioned. And this is what happens with ARIA. ARIA is basically an overwhelming of your drainage system. So we saw the data before. We're very effective in targeting the amyloid, and then the amyloid is being depleted, and it's all depleted into the sink, and it sometimes causes these responses in the what's it called, the endothelium, as well as in the brain, and this may cause leakages, edema, or even bleeds. So this is the pathology, and we know this for many, many years, as I will show you a little later. This is how we will manage it. I haven't managed a case yet, but we've seen all of these MRIs. It looks like a press. It's a press pathology, and this is one with edema, and so it's an ARIA E. If there were hemorrhages, it would be an ARIA H. This is a very interesting study by Professor Nichols in London. He's a neuropathologist, and what he has done is he has evaluated patients that were in these very early immunization trials in the 2000s, early 2000s. There was a number of trials that were done when this concept was first evolving, that you could target the amyloid with monoclonal antibodies. And it wasn't well received because a lot of patients had the ARIA and had all of these things, and in the early 2000s we weren't so good at managing it. So these patients continued to be followed, and this study, I think, is from 2016 or something. So he followed them for up to 14 years, and what he found was two things. Number one, the removal seems to be stable. So if you removed it once, even after 14 years, when they die a natural death of something else, you still find in the brain that the amyloid is not replenished. And number two is the diagnosis is often wrong. So even in the trials where the specialists are looking at the patient and they're really trying to make a good selection, they still are unable to get the right cases in, which means that we need to have biomarkers. We cannot treat patients without biomarkers. So if we want to move ahead and treat patients, we need to come up with a pathway, including biomarkers, that ensures us that we can do what Professor Dickinson told us, that we actually really know where we are, amyloid stage, tau stage, or something else. Good. So the conclusions, environmental and genetic influences, as I mentioned, the ones that are frequent in the population are less so associated with Alzheimer's than the ones that are infrequent, thinking of the presenilin or the ApoE4 mutation. Long disease maturation, and I called it prion-like, because we all know that the prion incubation time is like decades. But it seems, at least from the Colombian families data, that we have 21 years as well, from first recognition of the pathogen to the disease. And it is more complicated than I put it in front of you now, but I think we need to take the main point home, that this is a long time and that we really don't know whether we're going to have Alzheimer's disease at the time when we need to be evaluated. Then we talked about the amyloid and the tau PET imaging, which I think has to do with finding out where in the disease course you are with an individual patient. The Baptists and Taoists we leave out because I didn't bring it up. Then the CAA and the AD, we can do this. CAA is the cerebral amyloid angiopathy, and it is a marker of being, you know, maybe not eligible for these kind of treatments because you already have some sort of an ARIA-H. And so it's very important to do an MRI scan with a GRE or SWI mode before you want to enroll these patients into any treatment. Yes, not quite done. ARIA, longevity of amyloid. Yeah, I showed you that it's actually very long-lived, up to 14 years, that this depletion can be determined neuropathologically. So epidemiological studies in the MENA region are urgently needed. We really need to come up with a way to figure out what is the prevalence here. In particular, when we look at all of these different racial ethnicities that, in particular, Dubai are very common. Diagnostic setup: we need an MRI PET, which we don't have here, and I told you why. We need to have clinical evaluation centers. Maybe they could be called cognitive health clinics. The best severity and impact scales from the MENA region need to be decided. So we need to do all of these assessments like the MOCA and the MMSE. Those are the right tools to be used in Arabic-speaking people as well. And there is already some literature out. People have looked at this, but we need to determine what we choose. Then we need to train healthcare personnel for screening, diagnosis, and management is a priority, because the application of a MOCA test, for example, takes 30 minutes. It doesn't have to be done by the physician, and it doesn't have to be done by a neuropsychologist. So we need to train other people to help us doing this. And then, last not least, the population acceptance for early screening and intervention for mental health concerns, including memory loss, is crucial. And I put here, similar to the use of the statins. So I could imagine that this could be part of a executive examination program for people in companies over the age of 40 or something like this. And so we need to think of this, because if we don't, we may always be too late. And if you remember the slides from the last speaker, Dr. Tarazzi, he didn't speak about an improvement. He spoke about slowing of the curve. So it means they get worse. And mind you, these patients started with a dementia rating scale of 2.5 to 3.4, and the dementia rating scale that he was referring to is like the ranking scale in the stroke world. We would never treat a stroke patient with a ranking scale above 3, with a thrombectomy, for example, because we know that they're not going to get any better. So we need to think about these things. Yeah, this is just the idea of a memory clinic, what it needs to have and what it needs to do here in the region. We can talk about this another time. And I want to point out the artist on the right-hand side again shows what she felt, what her mother did before she evaporated into nothing. Yeah, the brain just drained, and there was nothing else. And I think this is an important Very powerful piece of information. This is just a very, very short idea. It says that the yield of treatable conditions in memory clinics has doubled. So whereas we only had hydrocephalus and depression in the early days when this study was done in early 2000, we now have to tackle 50% more patients with presumed Alzheimer's disease. So it is worthwhile spending money and effort in this. And this, I think, we can cut short. Suhail, we should cut this a little short. This is some of the, like a rebuttal to what we just heard about the ENGAGE and the EMERGE study. And I just want to focus on this to show you where these studies were performed and how many, geographically, how many countries were involved. And also how many patients and what the MCI was. These are the inclusion criteria, and we have already heard this from him. And then this one I wanted to skip. This is the issue. The trials were stopped prematurely, and because the trials were stopped prematurely, we don't really know how they would have continued. And the other issue is, we were talking about this dosing scheme. So you are at 1, then at 3, then at 6, and then at 10, over a period of 6 months. So the time spent on the high dose is not the same for each randomized patient into the high dose. And this is one of the reasons why stopping the study for futility was definitely a mistake. And things happen, but they did an analysis to look at this in those patients, or looking at this for the patients that were actually on the highest dose compared to the other patients. And you can see here, these are both studies, 301 and 302. They are trending now in the same direction. So for whatever randomness, it was that one study had fewer times on 10 milligrams than the other one. And that may, I'm not saying that this is the answer, this is an exploratory study, and an exploratory study is not an answer, but it explains a little bit, and this controversy of one study positive, one study negative, they are actually comparable. And if you take the biomarkers on top of it, which were the same and very profound, making a lot of sense, I think we should, this should be a message for the naysayers to be a little bit more receptive of this. So my take is, given there were no modifying treatments available for Alzheimer's disease, it's understandable that most patients are in a desperate search for the one approved that will delay the onset or reduce the progression of this devastating disease. Any treatment made available must be beneficial and not unleash a risky precedent that could derail the work being done to develop an effective treatment for Alzheimer's disease. Approval of a drug or treatment that is not effective has serious potential to impair future research into new medicines that may effectively treat Alzheimer's disease. This is what we definitely have to keep in mind, is in my opinion. So now I finish up with a case, because I was starting the process of screening patients for the aducanumab program about 3 months ago. And this was one of the patients that came across that I did start on the treatment. And it is obviously very premature, because she has only received one treatment so far, but I just want to give you my thoughts on this. So it was an 80-year-old female with non-insulin-dependent diabetes mellitus. So 80 years. So it was a woman in that second Alzheimer. So it's that Alzheimer-type dementia rather than Alzheimer's disease. Memory deficits diagnosed as Alzheimer's disease approximately 4 years, according to her son, initially treated with memantine and donepezil, and he said it was actually arresting the progression, so she was doing well, but now they wouldn't work anymore, is what he said, and this is why he sought my attention. So it was a deficit in memory and verbal fluency, impaired executive functions that we tested. Currently, she was mostly independent with only little need for caregiver help. She needed to be prompted on some tasks. The son decided to consult me for an opinion about the new disease-modifying treatments that he had heard about. Her neuropsych testing results were MMSE 2430, MOCA 2030, 3 frontal assessment battery 6 of 18, Addenbrooke CE 66 of 100, and the CATS index 8 of 14. This has been done in her language by a local neuropsychologist. The MRI revealed volume loss, no microhemorrhages, wide anterior horns. The blood, the ApoE genotyping was E3, E3, so she didn't have an E4, which is good, because the E4 has a higher likelihood of developing ARIA H in particular, and they have more microhemorrhages. Her CSF revealed elevated tau. I didn't really want to see this, but that's what it was. The p-tau was 106, the total tau was 700, so approximately twice elevated. And the beta amyloid and the 140 and the 142 were put into the ratio, and the ratio was 0.5, and it needs to be above 0.7. So the ratio of the B amyloid 142 and 40 is much more important than the values themselves. And this is why we don't even have normative data on the amyloid 40 and 42 per se. We only have the ratio, and she met these criteria. And here you can see this is a study from not too long ago, 2004, when these things were first developed or reported. This is Alzheimer's disease on the left, an MCI convert and MCI non-converts into Alzheimer's disease, and the healthy control in terms of their ratio. No, this is the beta amyloid concentration, and then here it's the tau. And you can see that our patient fit the values that were seen in Alzheimer's disease patients in this cohort. And this is not the normative data that we use from the labs, but this is just to show you that this patient fit into the criteria, and also to highlight the way that I think we should enroll patients, or we should start initiating treatment in patients. They need to fit into the literature. We need to be sure that it's Alzheimer's disease. This is her MRI, which I already told you about. This is the GRE, and here you can see the atrophy, temporal atrophy, and then this is, she received her first dose, 1 milligram, on the 7th of February, with no complications. As we heard before, it's an injection basically. It's a 1-hour infusion we did, and this is the WhatsApp messages from her son after she arrived home from here, and so she's doing fine, and I've spoken with him again. She continues to do fine in terms of not having any side effects. So this is the end of my presentation, and if you want to evaluate this, please scan the QR code. Thank you very much.
So just I would like to inform you that this month we start the first patients on the monoclonal antibodies for Alzheimer's disease, and Dr. Derk was the first one outside the US to use that medication, right? So this is something nice. It's a new window. Hope that that patients will improve with this medication. We have a good number of audience here that they have many questions to Professor Trazi and Dr. Derk. So Dr. Haytham will moderate this. Please, Haytham.
I have a question. For
Hi, who's that guy? I know that guy. Frank, thank you for waking up
Yes.
so early and being with us.
Thank you,
Jason, you want to go ahead?
I just have a question, because the patient you started the drug is, it seems that it's advanced case. And I think the trial done and the improvement done in like early cases. But it seems to me that the case that started here is a bit advanced case. Is that what my understanding is correct? This drug, if you decided to start such medication, it should be started in the earlier stage? Is that correct, Haytham? Is that what I noticed?
The question is for Derek.
Yeah. So, but is that my observation was correct?
Yeah.
So is that because I thought it's severely advanced, the brain is really atrophied. She was started on Epixa, which is like for moderate to severe cases, and there was, is that approach is justified? I'm really very skeptical about this drug because I don't know, but that's my thinking about the drug. One study approved and one study disagreed, and will you think it's, and then the case here, because most of the cases, but I thought this drug should be started in the earlier. Is that my correct understanding of the drug?
Yeah, I can only echo what you just said. But unfortunately, the reality is such that these patients, the ones that you want to treat, they don't come to your office. And so this is a new drug, and I'm aware of the controversy, and I think I was relatively balanced in my presentation, and so were the other speakers. But you know, you are now a naysayer, yeah? So I think you need to get some experience with this medication. What I said to myself is, do not be a car salesman. Don't push somebody into this treatment. If they come and they want this treatment because they heard of it and they wish to give their loved one a chance, and I can establish the diagnosis and agree in principle with the severity of the illness, I am happy to provide this treatment under very careful monitoring.
Yeah, but
this is where we are now in 2022. It may be that in a few years from now, this will be different.
My concern is this, with this advanced, their endothelium is really, will leak because it's at advanced, and the area or whatever that you are calling because of the microhemorrhages, there will be more prone to these consequences compared to the earlier probably cases of dementia. So I would be very reluctant actually in such case.
I will take that. I have a questions to Haytham, Alessandro, and the others. And Jassim is there. This month, February, I had 2 patients present to my clinic with typical MCI. Okay, one of them is a mother of one of our physician local. Both of them are insured. Both of them, they came through their family because they know Suhail. They heard about this new medication. They said we didn't care about the money. We are aware about the side effect. We are willing to start this because how long we will wait, Professor Trazi, to get the other evidence or other trials? You said this will take 74 weeks, whatever weeks, and maybe a few years to get the approval. And these family relatives, they're concerned about their mother and father, both male and female. Their mini-mental were between 26, 27. They are not on any other medication for Alzheimer. It's only MCI that they presented for. Professor Trazi, what do you think?
Yes. I think this is more of an ideal situation. Am I echoing? Can you hear me well?
No, we are hearing you good.
Yes, okay. It's more of an ideal situation to enroll patients in the early phase of the disease, as I have shown. 27 is, I think, will benefit more on the long outcome. The FDA was very clear in the beginning. They approved it for Alzheimer's in general, but then they revised the language, a couple of weeks later, and said this will only be to the mild patients or even MCI. And at this stage, to minimize the incidence of ARIA, I will prefer to go with what you have suggested rather than having a patient with already the disease has progressed and has a moderate score, moderate stage. So definitely an earlier stage of the disease, patients will benefit more based on the clinical trials that we have had, for the data that we have.
Dr. Haytham and Alessandro, what do you think in this scenario?
Yeah, so let me just, before I think I speak and contribute, I will disclose that I have no conflicts of interest, received no support or grants from Biogen or from any other company. I am the president of the Saudi chapter of Cognitive and Behavioral Neurology, the companies support the activities. We do not get any financial incentives from them. And so here's my take. I think the issue at hand here is whether we are going to be successful balancing the grave need of patients and families and the pressure and the agony and the psychological distress that everyone is going through with our responsibility really to do no harm. And this is not something to be taken seriously. I think there are even corruption investigations that were reported. There are deaths that are reported. Just last week, the American Academy of Neurology's subcommittee published their guidelines recommending not using this medication. There is a strong wave against using this medication outside of clinical trials. I know that this medication is approved in this country, right across the border from you in Saudi Arabia. The Saudi chapter issued its expert recommendations saying that we need to restrict use of this medication. And even if the Saudi FDA approves it, the professional society will maintain its position that it has to be used in the context of clinical trials. And we in Saudi Arabia do have PET scans widely available. The tracer is somewhat available. But we still argued that we're in no position to start treatments with this medication because of the significant deficits in infrastructure that we have at the country. And I think the situation is somewhat similar in this country as well, in many regions of the world. The neuropsychological testing tools that we have are not well validated. We don't have the data. People are not astute in reporting their symptoms early, and so on and so forth. So even in a country like the United States, where all of these things are available, the professional societies are. There's a revolt against widespread use of aducanumab, and I think that is just in light of the data that we have that Professor Tarazi so nicely presented. We are all eager to have a treatment, but I think no one is eager to hurt someone. I think that's what it comes down to.
There is no cut-off age, right? Yes. There is no cut-off age for this thing.
It's not, I think...
Haytham. With all the respect, Professor Tarazi showed us that both or the three medications, they significantly between 40 to 60, Professor Tarazi, that the amyloid accumulation is going down, right? That showing the progression of disease is controlled or coming down. I'm getting patients as a community between two brackets, neurologists, patients are coming and they're asking, treatment is here, shall you give it to me or I will go to, I was going to give an example of Ukraine, no, to go somewhere else for the treatment. Okay, so why you don't treat me? So how we will deal with this, Professor Tarazi, then Alessandro, sorry.
So I'll start. I'll say, we have to be very careful by selecting the right patient for this. It's not, you don't want to turn our patients into experimental tools unless they are enrolled in a clinical trial. So you have to give your honest opinion, and then it's up to the patient and the family. But at least from our side as clinicians, we should select the right patient who we think will benefit the most out of it. There is nothing you can stop if this patient goes out and find another doctor who will accept to prescribe it or go to another country and get it. But at least, from your own perspective, that you have done the right thing by discussing with the patient, the data, the evidence, and then, telling him whether this patient, I think that you are not the candidate for this treatment and you should not take it. If he listens to you, that's fine. If not, at least you have done your job.
Alessandro, please.
Thank you, Zubair.
You are the
So
moderator.
I think that, I mean, science is mainly based on curiosity. So I can understand that we can be all curious to see it, to challenge a new drug for the sake of our patients. But at the same time, we have to be responsible, not only because of safety, but also because it has to be responsible in the way we use our science. And science is medical, is based on medical evidence. And even in my opinion, at the moment, the data are not strong yet enough to justify a broad use of these kind of molecules. We have to very, very carefully select potential candidates, not just because the family or the patient is pushing, is asking for the treatment. It's our responsibility to say you can be a good candidate or no, you are not. And if the family or the patient goes somewhere else, that's another doctor responsibility. We have to be very careful in the way we choose our potential candidates. I think the moment is not ripe yet to go straight away to jump into these treatments. We have to take more time to better select the cases and review the data on the long term.
Just we will give questions because we have 4 or 5 people there.
I just
علي جاسم لأنه واقفين الشباب دقيقة اسمح لي.
So much.
علي 10 seconds question.
Okay, so first question, it's 2 questions, so because I'm waiting for 15 minutes now. So first question, Dr. Tiasi, you taught us about 4 types of AD amyloid PET scan, because I already talked to my PET scan and they have FDG, but they asked me which type of amyloid you need, because there's many types outside USA, one coming from South Korea. So they are waiting my BI, which type of amyloid bakers they need in the PET scan, which is the best one, can we use it?
I think, you know,
So
the
question number 1 regarding the amyloid PET scan. Question number 2.
Question number 2, are we need to go back to pathology and looking for another marker other than amyloid and tau only, because the study showing a very good response in controlling amyloid, but this is not clinically correlated. So do we really know everything about pathology of Alzheimer? Or
So
have to go
question
back
to
again?
Professor Tarazi. Is it tau and amyloid, or we need to go back to the basic science, pathophysiology, and find another reason for Alzheimer's disease?
Yes.
Which type? Yeah, Shabab.
Okay. Want to answer?
Yes, Prof.
Yes. So I think for the first scan, the one that we use most often is called Amyvid, which is produced by Lilly. And I think Dr. Dickerson had shown some interesting data using, you know, this scan, and it is widely and clinically used right now as the PET scan, at least in clinical trials, to validate or quantify the levels of beta amyloid. So, you know, there are 3 of them, yes, but Amyvid is the one that is the leading radioisotope that is currently used in PET scans. For the second question, this is a very valid question, because are we, you know, still knocking at the right door? Is beta amyloid or tau the right biomarkers that we have? And, you know, as you know, many till now question whether beta amyloid is the right target to go after, because you expect once you get such a profound clearance in this biomarker, that you should get more significant improvement on the behavioral symptoms, which we did not. So, you know, I can say that beta amyloid could be a player, but not the player that is responsible for a complex disease like Alzheimer's. So I think, you know, definitely in addition to doing clinical trials at this stage, there is a need still for preclinical research to try to identify better targets, better biomarkers. But this is not an easy task. We have been doing this for the past, 20 years. And I hope we will be able to find additional biomarkers that will guide the development of new and improved treatments over the existing ones.
Thank you.
Thank you, Prof. There's a question there.
Yes. So, first of all, I will be very fast. Congratulations to all speakers for the brilliant talks. My question would be a combined question for Professor Tarasi and Professor Krieger, and also being in the same sense of Professor Tayeb. So is there any, are there data suggesting that these drugs are safe in patients that have autoimmune diseases? Because I think that in this moment, the data would suggest these drugs are not effective So Professor Krieger's arguments for me is valid, right? There is no other treatment, so there are going to be a lot of patients that will be needing rescue treatment for the disease. And we will treat these patients based on safety issues, right?
Just I will ask Professor Tarazi the question. The question is regarding the safety of using these medication in autoimmune disorder patients.
Yes, absolutely not at this stage. There is no evidence to validate the use of these aducanumab or other monoclonal antibody outside Alzheimer's disease. Even in other types of dementia, like frontal temporal dementia, FTD, or Lewy body dementia, most of the people, the clinicians have voted against using it in these patients, which is still another type of dementia. So at this stage, all the focus is on Alzheimer's disease. It is not recommended because we have no data. The data in Alzheimer's is still controversial. To extend it to other diseases, it's still very early. Let's try to see whether it works in the main disease we're going after before we start exploring it into other diseases, especially autoimmune diseases.
Thank you. Professor Tarazi, correct me if I'm wrong. My understanding is that the question was the chicken and the egg. My understanding is that amyloid is detected very early on during the disease course of a patient or a prospective patient. We don't know exactly whether there's more going on or whether amyloid starts another process that we should attack with future other weapons. But I think we're under the understanding that amyloid is a basic, important disease part. So it's the chicken and not the egg. And we should now, with a tool in our hands, try to treat those patients where we don't do harm. Is that correct?
Yes, at this stage, yes. But you're right. What we say that there is the hypothesis of neuroinflammation, because there is the question, what causes this beta amyloid to start accumulating? And a proposal here is that we may have some neuroinflammatory, deficiencies or abnormalities that eventually lead to the accumulation of beta amyloid. But beta amyloid, it's easier to detect on the physical, terms, in terms of ability to image the biomarker and to follow it during treatment. We don't have at this stage tools to evaluate the neuroinflammatory pathway at the cellular level to be able to determine if such an impairment eventually leads to the development of beta amyloid and consequently to Alzheimer's disease.
Dr. Abubakar?
Thanks. I have issues to implement MMSC and MOCA religiously in GCC and UAE, and we discussed this on Friday. So probably, I'm not against or with giving the medicine. Probably your patient has MCI here, because the MMSC was 24, right? Yeah. What Haytham thinks about it? I mean, implementing MMSC in our culture is not...
Can I know why? Why it's not culturally accepted to implement MMSC?
Some questions are not existing in our culture.
I think the question is whether it's got sufficient validity, validating it against more gold standard neuropsychological tools, and that's not, there's some evidence for the MOCA, there is some evidence for the MMSC, but again, there's really not a lot of evidence, probably because of insufficient availability of well-trained neuropsychologists.
I'll give you an example. 85-year-old who runs his business independently. I did just for sake of doing it. I did an MMSC for him. It was 15 out of 30. And he was running his business.
What's the business?
He's a billionaire.
So that we take out our stocks if we had stocks.
What I'm missing is, and maybe we can discuss this, I think this is a very valid point, that in different areas where different traditions are, people in this area, they are different from people in Europe and people in the US, where these things are mostly done. These tests have developed. So yes, there may be, I mean, the MOCA test is pretty simple, and I would imagine that it's relatively fine to use in any of these. But for example, in this area, maybe caregiver assessments should be more taken into consideration as they are in Europe, because of the different status of these people under consideration in their 60s and 70s in terms of, being the head of their clan and things like that. Maybe you can...
Yeah, I mean, I think there are a lot of infrastructural deficits. You can even bring in religiosity scales into the issue. There aren't enough trained psychologists. So there's a lot of work to be done, and I think all of this is reason for pause when we try to think about giving people these medications. So yeah, there's a lot of work to get done.
And this is what we have, because I'm using Muka in Arabic, and it's when you ask the patients to do the repetition, the line or the sentence that we are using is Abu Salim zara jarahu wa atmanna ala sihhatihi. This is not the normal language that we are using, okay? Second thing, when you are saying that when the dog entered the room, the cat, we don't have cats, neither dogs in our rooms usually, so that is not a common thing that we are using, okay? So I think that need to be...
Yeah. Well, I can tell you that there's some work going on in Jeddah to create a Jeddah naming test instead of the Boston naming test. At King Saud University, there's work going on creating new tools. So and as a matter of fact, when just a couple of days after the aducanumab got approved, the company approached the Saudi chapter of behavioral neurology after our statement, and we clearly stated that we are willing to forge a collaboration between professional societies and between industry with everything declared and so on, with one of the goals being developing new assessment tools. So I think that's the right way to go about it. I think being a naysayer is not good, but I also think one needs to have a very systematic and very well validated and justified approach. And I think in the States, we're only using this, it's recommended to use this medication in the context of clinical trials. Here, we are using it outside of clinical trials, and even without, we risk using it even without being replicating what happened in the trial, because we don't even have the imaging to base that on, and the validity of our tests isn't exactly the same. So there's a lot of reason for caution here, I think.
Yes, and also not to forget about screening for depression, depressive conditions that also because of the cultural bias can be just hiding in the background and can be giving a false case of initial cognitive deficit, and maybe it can be another diagnosis instead.
I think I totally agree with that we have to be cautious. I have screened 10 patients so far, and I have found one patient that I felt was reasonable to treat because the patient wanted the treatment. So this is 1 in 10. I agree that the scales that we use, the scales that we saw, they are very broad.
Objective.
And all they do is they tell us how severe is the dementia. How severe is the dementia? And what I also found interesting in the first talk from Dr. Bruce, dementia may be a precursor of Alzheimer's disease. So, it's not like, you rule something out, the cognitive health clinic is ruling something out. I think we need very solid biomarkers. I think that's what we need. And in this country so far, where the infrastructure doesn't allow us to do the PET scans, the FDG PET scan is not helpful. It is helpful in being sure that it's an Alzheimer's disease, for example, when you have clinical evidence for it. But I think what you need is a PIP scan, or you need to do a lumbar puncture of these people. And the question that I have is, there was an Alzheimer blood test recently approved by the FDA, and I was wondering, what is this blood test, and is this something that we could use instead?
Yes, excellent point. So absolutely, there is now a tendency or going towards using more simpler tests, whether a PET scan and it's more accessible. or a CSF spinal tap. Is that not easy and not that accessible? And spinal tap sometimes can be associated with side effects, especially headaches. So there is a test right now developed by, I think, a company called C2N that looks at potentially the higher levels of beta amyloid in the plasma. The thing about this test, it is at this stage in time, it is morely as a screening tool. You cannot base your diagnosis only on the blood test. But the blood test can be useful as a screening tool. And if the blood test will show abnormality more than expected in terms of the higher levels of beta amyloid, then this will justify additional screening. But we still have to go through PET or to the spinal tap before making the right decision to start infusing the patient with this disease. So at this stage, we are moving forward. These companies are trying to increase the sensitivity and the selectivity of these blood tests. And I think they are going to be very useful down the road as a much easier screening tool, perhaps to screen patients, as during their physical at a certain age. But at this stage, they have not been reached enough sensitivity to be used as a final screening tool to make a medical decision whether to treat the patient or not. They are useful only to highlight these patients, but these patients will require going forward additional evaluation through PET scans or spinal tap.
Thank you, Prof. Dr. Osama.
So Frank, just a final question, perhaps. Across town from you, Risa Sperling and colleagues were doing the 4A study on asymptomatic individuals with solanezumab, I think it was. And I know that I think this study got halted. Are there? I'm not aware of any publications specifically. Are there?
Well, there are still ongoing trials with number of antibodies. I didn't have the chance. I have to say first, I'm sorry I went over time. It gets a little bit tricky to keep track of time when you do virtual talks. But there are still ongoing trials with number of antibodies that we should know more about. The study by Dr. Sperling and others are still in early stage. We haven't had, final or recent data or outcomes on them. But, the field is not open. All what I want to say about aducanumab, why I said it can be a turning point. Aducanumab is not and will not be the best drug for Alzheimer's, but at least it's the beginning. It generated so much interest from other pharma companies to try to bring even better ones. Dr. Price mentioned a little bit about HIV. The first drug that came for HIV was not the best one, but it opened the door for better ones to come. And that's what we hope in Alzheimer's, that aducanumab is opening the door for more and improved antibodies to come. The data with donanemab at this stage looks promising. Hopefully we can get better outcomes in terms of behavioral endpoints. And maybe in the future, we can even get much better treatment. But I'm excited going forward right now, saying that there are promising things in the pipeline for Alzheimer's. We spent 18 years with nothing. So step by step in the right direction. We should not judge the whole concept as a dead concept because the data of aducanumab was not as we anticipated or we hoped for. But I think maybe before better ones to come, the field is still wide open. And I agree, we are still in great need of these new and improved treatments.